Good evening and welcome all to the college webinar of Wednesday. That in 2 weeks' time, we'll be having our Grand Gala National Program. This will be our 4th international as well as 14th National Conference of Indian College of Anesthesiologists. This is going to be on 2, 3, 4, and 5 of November at Narayan as well as Sai Vishram Business Hotel, which is near to Narayan at Bangalore. Well, the program is a really packed program. And the day 1, that means 2nd of November, will be the continuing medical education program spread over at different colleges and will be handled by well-known faculty members of Karnataka as well as outside. 3, 4, scientific programs, and 5th will be our Java matches as well as one short but an exhaustive program on the mentoring of postgraduates as well as the juniors who are in the profession, looking after their welfare, how they should go ahead, and what is good for them in the store. And the program is published already. Dr. Moderator is the chief organizer, and Dr. Bindu George is the CMA coordinator as well as the scientific committee chairman. And I welcome on behalf of the Indian College of Anesthesiologists for our national and international conference on the 2nd, 3rd, 4th, and 5th of November. And with these words, I conclude here, and I invite Dr. Singh, our Chief Executive Officer of the college, to moderate this session. Beljeet, please.
Thank you so much, sir. Well, friends, this is a continuation of the ICA webinar that is a routine with us for the last few years. This is the 170th Indian College of Anesthesiology webinar. The topic is very interesting. I would say interesting from the point of view that this is something that we deal with, with this on a daily basis. Pain. With the passage of time, we have realized that treatment of pain is very important in the perioperative and the pediatric age group. There was time when pain was not paid much attention. See, everybody used to say, "Arey, surgery hai, thodi pain to hogi, so take it easy. It's not going to." But as science grew, we came to know that treatment of pain is very, very important. Not only from the point of view of the patient comfort, but there are a lot of physiological changes which take place, and apart from that, in case we do not treat pain, it can lead to chronic persistent, pain, which is very, very difficult to treat subsequently once it establishes in the patient. So, to take up this topic, we have the moderator. I think there was some error somewhere in the previous announcement. The moderator for today's session is Dr. Anju Singh. I'll have the introduction of Dr. Anju Singh. In fact, I was saying that who doesn't know her? She's one of the most vibrant person who has defied age. Nobody can ever guess. She's as young as ever she was, when we were colleagues in Lady Hardinge about 15, 20 years back. At the moment, she is a director professor, Lady Hardinge Medical College and Associated Hospital. And she has administrative experience of establishing the Delhi chapter of Indian Association of Pediatric Anesthesiologists, and currently is the president of Indian Association of Pediatric Anesthesiologists, Delhi chapter. She's ex-vice president of Delhi chapter of Indian Society of Anesthesiologists, 21-22. Lot of awards. Academic Excellence Award in Medical Sciences 23, awarded the Honorary Fellowship of ICA, ISA Daily President's Appreciation Award 2022, ISA Diligent Award 2022 again, and the COVID Barrier Award by Medical Wing of Brahma Kumaris. And then from the academic point of view, she is AHA and BLS and ACLS courses instructor. And she is senior faculty in the Airway Management Foundation, faculty of MET workshops, examiner. She has traveled extensively for DA, DNB, MD examinations all over the country, reviewer of national and international journals, more than 250 publications, a huge number. More than 70 in national and international chapters in books, and she's assessor for National Board of Examinations for Medical Sciences and National Medical Commission, membership of various prestigious societies. Her area of interest, apart from pediatric anesthesia, is obstetric anesthesia well, and life sport that she does so very well. So, Dr. Anju Singh, it's over to you. I would request you to introduce the speakers and take on the program further on. Over to you, Dr. Singh.
Thank you very much, sir, for that very, very kind introduction. And thank you, ICA, for giving us this opportunity to discuss such an important topic, that is pediatric perioperative pain, a topic which is not very commonly discussed. We do talk about pain, but we leave out the pediatric patients out of this pain discussion. So we're trying to improve that today. And just a brief introduction, as Sir has already said, that pain is no longer acceptable. The Declaration of Montreal has said that access to pain is a fundamental right. But still 80% of the population in the world does not have access to adequate pain relief. And the greatest burden of this inadequate pain management is carried by pregnant and breastfeeding women, mentally ill individuals, and children. Although there is an increasing awareness about pain management in children, but still a substantial number of patients do suffer pain. And this is across the board. This happens in developed countries as well as developing countries. Just because they're more developed doesn't mean that their patients, pediatric patients, have universally good pain relief. It is very variable and suboptimal in many centers. So today we are trying to improve this situation. We will discuss the assessment of pain, the management of pain, and everything that we can do to improve the delivery of pain relief to pediatric patients. And we've assembled together a galaxy of pediatric anesthesiologists who are stars in their own field. They not only have extensive knowledge, but they have this vast clinical experience because they have years of experience with pediatric patients, which they will share with the audience who's listening in. So with that brief introduction, I would like to introduce our first speaker. Give me a minute to share my slide. Okay. Our first speaker is Dr. Anju Bhalotra. Anju Bhalotra is the Director Professor at Maulana Azad Medical College. She's a very learned colleague. She's a gold medalist and first rank achiever in MD Anaesthesiology AIMS. She's a certified AHA ACLS instructor. She has many publications to her credit, is on the review board of several journals, and is an important member of the specialist board for anesthesiology at DNB. So inviting Dr. Anju Bhalotra for her talk on assessment of pediatric pain. Dr. Anju, please.
Thank you, Dr. Ranju, for that kind introduction. I'm sharing my screen. Right at the outset, I would first like to thank the Indian College of Anesthesiology for giving me this opportunity to participate in this webinar. The topic given to me today is essentials of pain assessment in children. I'm audible, Dr. Anju?
Yes, absolutely.
Thank you.
Yes, yes.
My topic for today is the essentials of pain assessment in children. Now, as already has been told by Dr. Baljit and Dr. Ranju, Pain is a very unpleasant sensory and emotional experience, which is associated with actual or potential tissue damage or described in terms of such damage. And if this pain is untreated, it can lead to short and long-term psychological and physiological adverse effects. In fact, pain assessment has become a requirement of proper patient care, and it has been counted as a fifth vital sign, along with temperature, pulse, respiration, and blood pressure. Now, having said that, how can you manage pain without assessing it? So when we talk about the stages of pain management in children, it starts and it goes around assessment. The first step in any pain management is to assess the pain. So we have to assess the child's pain, and only then, once we've assessed the degree and the amount of pain, can we select appropriate pain relieving measures. And then we can implement these pain relieving measures, and then again assess to evaluate the effectiveness of these pain relieving measures. So this goes round and round, and the starting and the ending point is at assessment. But unfortunately, there are many challenges to proper pain assessment in children. It is often ignored, it is often inconsistently done, and it is suboptimal. This is due to many reasons. First of all, children have trouble understanding, expressing, and communicating their pain. In children, pain is very subjective and complex in nature. Children below the age of 10 years have a delayed acquisition of the body scheme and conceptualization, so they are unable to locate precisely where their pain is originating from and to describe their pain properly in many situations. Then in many children, especially the smaller children, the healthcare workers are dependent on others, the parents or the caregivers, to infer the pain from behavioral and physiological indicators that the child might be showing, even if the child is not able to vocalize his pain. So this makes pain assessment a little more time consuming than it is in adults. And then there is a lack of awareness of the pain assessment tools which are there for pediatric pain. And all these challenges are amplified in the preverbal, the smaller babies, and the developmentally disabled children, which, as Dr. Ranju has said, these are the main sufferers of inadequate pain control all over the world. So the objectives of my talk today will be to discuss the various approaches to pain assessment, to describe the type of tools which are used for pain assessment, how do we choose which tool to use, how frequently should we assess the pain, and why must we document this pain very diligently at all times. Now, assessment of pain in children is multifactorial, and it requires a very systematic approach. One such approach described as QUEST. So you can question the child. If the child is for an elective surgical procedure, it's a good idea to question the child before the surgery to find out what are this child's expectations, what are his perceptions, has he had any previous bad experiences of pain, and you can explain, you can allay, and you can reassure the child accordingly. But of course, this will be for the child who is able to talk and communicate with us. The U stands for use the age and developmentally appropriate pain rating scales for assessing the pain in these children. Evaluate the behavioral and the physiological changes, which I shall be describing subsequently. Ensure and secure parental involvement in the management of pain in these children. Take the cause of pain into account, and then take action and implement pain relieving measures, and then again evaluate the results of these pain relieving measures. Now, there are three approaches to measuring pain in children. The first is called self-reporting, in which is what the child says. I mean, what pain he has, he tells us how much pain he has. This, of course, is the gold standard, because this is the only way we'll really know how much pain the child has. But this is also subject to many biases, and this is also has to be supported by other ways of assessing pain, which are the behavioral and the physiological indicators. The behavioral and the physiological indicators are what we may only have in the smaller children. We may not have the self-reporting in the smaller babies, so we are dependent on the second two methods of pain relief. So to summarize, there are three methods of pain, assessing pain in children. The first is self-reporting of pain in the older verbal child, behavioral cues which can tell us that the child is having pain, some physiological changes which tell us how the child's body is reacting to the pain that he's feeling. However, of course, as you can all understand, the most reliable indicator of pain will be a combination of all the three, which will be a multidimensional or a composite pain assessment should be done at all times wherever possible. Now, what tool should I use for assessing pain? As we go along this talk, you realize that there are so many tools and it's so confusing. And out of all of these tools, we should choose that which is appropriate for the child's age and level of cognition. That tool that we use should be practical for use in the clinical settings, and it should be understandable to the patient and to the caregivers. This tool should be reproducible, it should be reliable, it should be valid, and it should be transferable amongst the different assessors. This tool should be chosen in collaboration with both the child and the parent. And this tool must be adopted by the institution, and all the healthcare workers must be trained in the usage of this tool. And ideally, pain assessment tools in one particular clinical area should all use a common metric. For example, pain will be rated from 0 to 10. So you know that more than 4, the pain is very moderate or severe and needs to have some form of pharmacological treatment. Now, coming to the first method of assessing pain, as I've said, the first one is self-reporting. This, of course, is the gold standard because the child knows best how much pain he's feeling. But this is not possible in the smaller babies who are young, not old enough to report their pain. So it can be used only in children who are more than 3 years of age. And it cannot be used in very distressed individuals, babies. They will not answer when you ask them how much pain are you having on a score. So you cannot use them in the very distressed or the very cognitively impaired children. Now, having said that, when we talk about the self-reporting tools, there are so many in the literature. There are more than 60 self-reporting tools. Many of them have been validated. But when you come down to the crux of it, the recommended scales which are universally used are only a few. These include the visual analog and the numerical rating scales, the Faces Pain Scale, which is original Wong and Baker Faces Pain Scale, and the revised Faces Pain Scale, and the Pieces of Hurt tool. Talking briefly about these, the numerical pain scale can only be used in those older children who are above the age of 8, who have an understanding of numerical order and value. The most common and the most popular numerical pain scale is the numerical rating scale, or the NRS. This is available in either a verbal or a graphic format. The advantage is that it is very easy to use. It is quick. There are no props required if you are doing it verbally. You can do this verbally, or you can show the child a piece of paper with a scale on it. If you're doing it verbally, then you do not need any props. And in fact, the verbal 11-point NRS is the most frequently used scale for the older children. So you can see this figure on the screen. So there is a 0 represents no pain, and a 10 represents the worst possible pain. And the child is asked to score his pain along that line. And then you assess how much pain he's having. As with all the 1 to 10, 0 to 10 pain scores, more than 4 is considered to be moderate or severe pain, and they need to have some form of analgesia given to them. The other numerical pain scale, which is commonly used, is a visual analog scale. This is again easy, quick, and versatile. However, this requires a child to understand proportionality. The initial scale is just a 0 on one end of the line. It's normally a 10-centimeter line. And the other end of the line represents a 10, which is if the child is told that 0 represents no pain, and 10 represents the worst possible pain that child can imagine. And the child is asked to mark a point where he thinks that his pain lies on. And then that point is measured, and then that is translated into a pain score. And now as we talk, we must understand that all these adjuncts which require pen, paper, pencil, they have cost implications, they have time implications, and also infection control implications, because if you pass that paper around to all children, you have to be careful that you're not spreading infection. The other way of numerically pain, the verbal pain scoring, is by use of a Faces Pain Scale. The original one was a Wong and Baker Faces Pain Rating Scale, in which there are 6 faces, and they depict scores from 0 to 10. These can be used in children again. This can be used in little smaller children who can understand, so they can be used in children beyond the age of 3 years old. They are easy, they are quick. However, the Wong-Baker Faces Pain Scale, which is the upper one, found criticism because the first face is too happy, and we don't expect that any child who's having pain will be smiling like that. So the children tended to give higher scores. And even the last face, which depicts the worst possible pain, will be limited by the tears, because not every child who's having a lot of pain will necessarily cry. So children were often not able to decide which face suits them the most. So these are the limitations of the original pain scale, and that has now been revised to the BRE faces, in which there are 6 mature faces, as you can see in the lower line. This can be used for children again from 4 to 12 years of age. It is again easy, quick, requires the use of a paper scale, and the child is asked to choose that face which suits his feeling of pain the maximum. The third one is only weekly recommended for children above the age of 6 years and may be used from 3 to 8 years. In this, there are 4 red poker chips. If the child picks up 1 chip, it means that he's having a little bit of pain. And if he picks up 4 chips, that means that he's having a lot of pain, or the worst possible pain that he could imagine. This again is a little time consuming. You require the use of chips, and these chips might get misplaced. And of course, wherever you are handling things from one child to another, there's a chance of carrying infection across the children. So that was the commonly used verbal rating scores. I've only discussed 3 or 4 of them out of the 60 that are available in the literature, and these are enough if you want to set up a pain assessment program. Now, coming to the other methods of assessing pain in children, these are the observational pain measures, and this is used in children who are unable to self-report. And this will be used in the children who are too young to self-report, like infants, toddlers, neonates, and pre-verbal and non-verbal children. The children who are too distressed to communicate, children who have impaired cognitive and communicative abilities, or children who are restricted by bandages, mechanical ventilation, and sedation, etc. These may also be used along with the self-reporting scale in children whose self-report seems unrealistic. So if they deny pain, but they seem to be in a lot of pain, or they say they're having a lot of pain and they seem to be very comfortable. So in those cases, you have to correlate the observation. You have to correlate the observational pain measures along with the self-reporting scores. So observational pain measures can be either by observing the behavior of the child or observing the physiological measures of what the pain is causing in the body of the child. Now, the common behaviors that are seen in children who have pain are changes in facial expression. They may frown, they may grimace, they may be crying. There's a disturbed sleep pattern. There's a loss of appetite. They may form unusual postures. They may be reluctant to move. Their hand and body movements may be restricted. They may show unusual quietness, restlessness, or lethargy, or they might be aggressive, irritable, and show increased clinging to the parents. They have different forms of crying patterns, which are difficult to decipher sometimes. They may or may not be consolable if the pain is very severe. And they may have they may be very rigid, lying scared, stiff, and scared to move because movement is causing so much pain. So these are the common behavioral cues that suggest that the child is having pain. Now, at this point, it is very pertinent to mention that neonates are perhaps the children who are the most ignored because they obviously cannot self-report. And as I'll talk about it, the physiological changes in them are very non-specific. So facial activity in neonates has been the most studied behavioral pain assessment measure. And you'll see that facial activity is going to be coming in all the pain scores in which neonates pain is being assessed. So this is how a neonate looks when he's in a lot of pain. You'll see 2 vertical furrows between the eyebrows, and the forehead is bulging out between those furrows. The eyebrows are lowered and drawn together. The eyes are tightly closed and the eyelids are very taut. The cheeks are raised. The nose is broadened and bulging. The nasolabial folds on either side are deepened. The mouth is wide open and has a squarish shape because of the increase in the vertical diameter of the mouth. And the tongue is very taut and very tense. So when you see this in a neonate, these are all indicators of pain, behavioral indicators of pain in a neonate. Now, coming to the third way of assessing pain, or the second observational pain measure, is the physiological measures. Now, this is nothing but the impact of the pain on the body, which gives rise to sympathetic stimulation. So there will be an increase in the heart rate, and then as the pain comes under control, the heart rate will start to settle down. This might be different in infants in whom the vagal tone is high, and there might be initial decrease in the heart rate with severe pain, and then this is followed by a rise in the heart rate. The respiratory rate might increase or decrease depending upon the site of the surgery, but there will be a significant change in the respiratory rate from the baseline respiratory pattern and rate, and breathing may become rapid and shallow. The blood pressure will rise if the child is in acute pain, and the oxygen saturation will decrease when the child is in acute pain because the metabolic activity is so high and the child is doing rapid and shallow breathing. Other measures of pain, physiological measures of pain, include heart rate variability, rises in intracranial pressure, changes in skin color. There might be pallor of the skin, mottling of the skin, pupillary dilatation, palmar sweating. Salivary cortisol levels indicate, again, sympathetic stimulation and stress. A functional MRIs are being studied, and near-infrared spectroscopy is also being studied to assess pain in smaller babies. However, it is important to remember that when used alone, these physiological indicators that I've just described are not by themselves a valid clinical measure of pain, and these similar responses may occur due to any form of sympathetic stimulation during stresses like fever, anxiety, and exertion. So it is very important that these physiological measures are considered hand in hand with behavioral measures, and if possible, in the little older children, self-reporting measures. Now, I already told you that there are more than 60 verbal tools and there are more than 55 observational pain tools, and it's absolutely mind-boggling. Again, out of these, a few of them which are more highly validated and reliable are, for neonates, we have the modified pain assessment tool, which can be used in neonates from 25 weeks preterm right up to 6 months of age. We have the premature infant pain profile, which can be used in preterm and full-term neonates. We have the CRIES scale, in which C stands for crying, R stands for requirement of oxygen, I is an increase in the vital parameters, E is expression, S is sleeplessness, and this can be used in small babies up to the age of 6 months. Another very, very popular and widely used scale is a FLAC, in which F is face, L is legs, A is activity, C is cry, and C is again consolability, which can be used in children of the ages of 2 months to 7 years. A revised FLAC scale has been used for children with cognitive impairment, and this is supposed to be the best scale for children who have cognitive impairment. It can be used right up to the age of 18 to 19 years. The comfort scales is a whole group of scales which have got various modifications, and they can be used for assessing pain in their different formats in patients in the ICU or in the critical care units. Now, just talking about all these scales briefly, we cannot go into them. You cannot remember them. You have to have them available. You have to have a chart near the child's bedside where you can calculate these scores. But they all are a combination of behavioral and physiological parameters. So as you can see, this one is a modified pain assessment tool. It has got 5 behavioral and 4 physiological parameters and 1 contextual parameter, that is a nurse's perception. So the behavioral indicators are the posture or the tone, the cry, the color, the child's expression, the child's sleep pattern, and the physiological ones are the respiration, heart rate, BP, and oxygen saturation. So this can be used in neonates. Another one that can be used in neonates is a premature infant patient profile. Again, this consists of 2 contextual, 2 physiological, and 3 behavioral parameters. We have the behavioral state, we have the physiological parameters, the heart rate, and the saturation, and we have the facial features, that is a brow bulge, the eye squeeze, and the nasolabial furrows. Then coming to the slightly older children from the neonate age group right up to 6 months, we can use a cry scale, which again has 3 behavioral and 3 physiological parameters. We have crying, we have expression and sleeplessness as behavioral patterns, and we have requirement of oxygen and increased vital signs as the physiological parameters. Then this is perhaps the most popular scale, which is used for pre-verbal and and non-verbal children, the FLAC scale. So F stands for face, L stands for legs, A stands for activity, C stands for cry, and the second C stands for consolability. So this is a totally behavioral scale. And as is written in italics, you can see that this has been modified for children who are cognitively impaired. And it is considered the revised FLAC is rated as the best tool for cognitively impaired children. Coming to the comfort scale, I told you the comfort scale and many of its modifications can be used in the critically ill patients in the ICU. These again is a combination of behavioral variables and physiological variables which have to be taken in tandem. The comfort scale B is another one which has taken away all the physiological parameters and it has only behavioral parameters to study. And this is used in children right from the age of neonates up to the age of 17 or 18 years old. Now, having said that, I've gone through these pain tools and they are very confusing, as I said at the beginning. And now we have to decide which one do we want to use. There are too many of them, and it is incumbent on every institution to select and adopt a single set of tools to train their healthcare workers in these tools and to use these tools consistently. These tools should be selected on their validity, reliability, and usability. And these tools should be, and frequent audits should be undertaken to see that people are actually implementing the use of these tools so that these tools are more and more frequently used, and assessment of children becomes part of the routine care of any child who's in the hospital undergoing a painful procedure. So in neonates, we can adopt the PIP or the premature infant patient profile or the modified PAT scale. In pre-verbal and infants, we can adopt the FLAC. For cognitively impaired children, you can do the revised FLAC. For verbal children, you can do the FACES pain scale and the NRS. And for children on ventilator, you can use a comfort score. So this is what is these are the scales which are used most commonly in most of the hospitals, and it is fairly all right for us to adopt these scales in our institutions and then get used to using them so that they become routine. Along with monitoring of other vital signs, these scales also become routine. Now, how often should we assess these children? I have talked about the scales. We should assess them. If we don't assess them, then pain management actually doesn't start. Because until you assess the child and you decide that the child is in pain, you cannot start any intervention. So in the post-operative period, pain parameters should be documented and some pain assessment should be done every 15 minutes until the child has received an optimal level of analgesia. After that, it can be done hourly for the first 6 hours after surgery. And then hourly assessment must continue in children who are on complex analgesia regimens like IV, opioid, and or ketamine, either patient-controlled or nurse-controlled infusions, or on regional infusions or epidural infusions. So all these children need hourly monitoring. Once the children move on to oral analgesia, then 4-hourly monitoring is quite adequate. Pain assessment should be done 30 minutes after the administration of rescue analgesia to see the effectiveness of the rescue analgesia. And pain assessment should also be done and documented on activities such as physiotherapy, especially after orthopedic surgery. If the pain continues to fluctuate, then regular assessment should continue for the first 48 to 72 hours, after which time the pain intensity will subside and the frequency of your assessments can go down. And it is important that the same scale should be used at all times. It's not that at one time you use one scale and another time you use another scale. Then you do not know how the child is faring along the way. The other very important thing that we must talk about when we're talking about pain assessment is documentation of this assessment. Now, pain is considered the 5th vital sign and it must be assessed and it must be documented along with the other vital signs. It should be assessed and it should be documented before and after giving any analgesia. And the availability of standardized forms and tools or charts in the various institutions will encourage an initial and ongoing assessment and documentation of pain. So it is incumbent upon various institutions who are looking after children and who are providing pediatric pain services to have scales in place, to have tools in place, to have a trained team of a pain team or a healthcare team who can assess pain in children and then document that pain. By documenting, we ensure a rapid and accurate communication amongst the healthcare team. It encourages a partnership between the patients, carers, and the professionals. It contributes to safe and high quality care of these children. It supports good clinical decision making. It documents the efficacy of the pain relieving interventions that we are doing, and it safeguards the children from any under or overdosing of analgesics. So to conclude, you must remember that pain recognition and assessment cycle. In any child in the hospital who is likely to be in pain, especially in the perioperative period, you must always anticipate that this child is in pain. Is the child in pain? Involve the parents and the carers to find out whether they think the child is in pain. If you are sure the child is not in pain, the child is quiet, child is sleeping, then you again document that and continue to anticipate pain. But if you have any signal that tells you that the child is in pain, then you must choose the appropriate pain assessment tool which has been adopted by the institution in which you work. And that tool will depend upon the age of the child, whether the child can self-report, whether the child has any cognitive impairment, is the child critically ill, sedated, or on ventilator. And once you've chosen that appropriate pain assessment tool, which has been endorsed by the institution and which all healthcare workers have been trained to use, then that pain must be assessed. That assessment must be recorded and documented in the file. Then a pain intervention must be given to the child depending upon that assessment, and that pain intervention should also be documented. And after that, the pain should again be assessed. And this is how the cycle of pain recognition and assessment goes on, because unless you recognize the pain, you cannot treat it. So again, I go back to my beginning slide. So assessing the child's pain using appropriate tools is the first step in ensuring adequate pain management. All the rest of the things come only after that. Only after that, you can give pain relief, you can implement it, and you can again evaluate it, and it goes around like that. So thank you very much for patient hearing. And this is the important points, salient features of pain assessment in children. Thank you.
Thank you very much, Dr. Anju. The talk was wonderful, not only very, very comprehensive, but very lucid. I'm sure the listeners have really benefited. Now that we've learned how to assess the pain, let's go to the next step and manage the perioperative pain in pediatrics. Regional anesthesia plays a very important role in this pain management. Regional anesthesia with all the blocks, peripheral as well as central nervous system blocks, have been given in children for perioperative pain relief for many, many years. The modalities, of course, have changed from the time when I was a resident and we used landmark associated blocks to the time when we moved on to blocks which were guided by a peripheral nerve stimulator, to the era now where ultrasound has come in. Now, the margin of error in children as compared to adults is small, and it's even smaller in infants. But ultrasound has helped us navigate this challenging landscape, enabling safe delivery of regional anesthesia, even in very small children. In fact, it's brought out a paradigm shift where many people who were reluctant to use regional anesthesia in children have now begun to give blocks. And those blocks, those nerves, which were never heard of 20 years before, can now be blocked individually with the help of regional anesthesia. Regional anesthesia forms a very important component of enhanced recovery protocols in children. And we have Dr. Rakhee Goyal here with us. Let me just show you her slide. Right. Is that visible? Yes. Just a minute. Right. So Dr. Rakhee is the Director of Anesthesia Services at Madhukar Rainbow Children's Hospital, New Delhi, and is also the Head of Clinical Services. Just a minute. Right. Sorry. Okay, now she is the director of the fellowship program for regional anesthesia, for pediatric anesthesia fellowship, and also the obstetric anesthesia fellowship. She is the recipient of Chief of Army Staff Commendation Award. She's the founding secretary of the IPA Delhi chapter. She's a postgraduate teacher for the Delhi University, a DNB and MD examiner. She's the director for the WFA Safe Pediatric Anesthesia course, is the faculty for Asian Society of Pediatric Anesthesia PPLS course, is the governing council member of RSACP, has many publications to her credit in national and international journals, is a peer reviewer for many, many anesthesia journals, and has presented a large number of papers in national and international conferences. Dr. Rakhee has many, many years of pediatric anesthesia and is just the right person to tell us about regional anesthesia and its benefit and pitfalls in pediatric anesthesia and perioperative scenarios. So here's Dr. Rakhee Goyal for all of you. The field is all yours, Dr. Rakhee.
Thank you. Thank you so much, Dr. Anju, and thank you, ICA, for this opportunity to share my views on the topic. Can you allow me to share screen, please? So today I'm going to discuss pediatric regional anesthesia, that bit of the pain management, the peri-op pain management for children. Can you see my slides? Can
Yes.
you just confirm?
Yes.
Yeah,
Yes.
thank you. Thank you. So greetings from all the children we care for, all the children who trust us, their parents who trust us that we're going to take care of the intense pain of surgery. So we owe it to them. And in a multimodal approach, we make sure that our kids of all ages feel comfortable at all times during and after the surgery. So obviously, why regional anesthesia in children? Just like adults, you know, the long list of reasons why you should give regional anesthesia. In children, they're particularly more relevant. If I see the point of opioid sparing, it's relevant in adults, but in children, say it's a 1-year-old child, would you like to give more opioids for the pain if the baby is crying in the recovery room? No. Would you want any hemodynamic instability because of the pain? No. So every which way, a child needs to be treated more aggressively for the pain he or she is undergoing. And there is nothing better than regional anesthesia when given properly. Still, we see that regional anesthesia is less commonly practiced in children. I think because of the issues of the perceived risk, both from the parent side, also from the surgeon side. Even with us, because we are less familiar giving a block to a small child, the experience may be less. We are concerned, always concerned that since they're given under GA, there could be systemic toxicity of local anesthetics, or there could be nerve injury, you know. So there is a perceived risk. But what assures the success of regional anesthesia in that case is, one is skills, expertise. You need to have the proper equipment. You know, in a small child, if you're giving an epidural, you can't use a long needle like you do in adults. You need a smaller 5-centimeter needle. You need appropriate catheters, appropriate size probes. You need supportive surgeons. You know, you need good assistance, and you need a good nursing care post-surgery as well. So if you have all these, then the success of your regional anesthesia would be more in children. Now, if you think that the same block, you know, the technique of blocks are by and large the same. So is it the same in children and adults? Absolutely not. As I said, the blocks are given under general anesthesia. Plus, the anatomy and the physiology of children, especially those less than 5 years, and more so in infants, in smaller infants, in neonates, they are so different anatomically, physiologically, that the whole pharmacokinetics and the dynamics are different. So you need to know. Unless you know the whole gamut in detail, you shouldn't be venturing into it. So quickly, I'll tell you the major differences. You know, the nerves are not just small. They're very close to the vessels, closer than that in adults. The adipose tissue is less, and they're very superficial. So, you know, you may just put in your needle and there is the nerve, you know. So, and they are less myelinated. Smaller the child, less the myelination, which means they're more naked. When you bathe them with local anesthetics, it's going to have a very early onset of both sensory and motor blocks, and there'll be a risk that these blocks are prolonged. So there you go. You need to titrate your drugs. You can't just give at the same dose milligram per kg as you were giving in older children or adults. You know, so this difference is very, very major. And there's a potential risk of injury because it's in GA. Or any kind of sedation. So you are not going to get any paresthesia or any input from the child. So you have to be very, very careful of where you poke your needle. Now, when it comes to central neuraxial blocks, you should understand that the dural sac ends lower in children. The spinal cord ends lower in smaller children, L3 compared to L1 in adults. Dural sac S3-4 compared to S2. So there's a huge, you know, there's a difference of 2 dermatomes. So if you're giving spinal in a preterm newborn neonate, you have to give it at a very, very low level, L4, S5, L5, S1. Even when you give a caudal, which is a very common block, the commonest, I would say, in children, you have to be careful of what length needle you choose. If you choose a longer needle, you might go and cross the dural sac and land up giving 10 times the volume of drug that you intend to. So into the spinal space. So it's extremely important to understand the anatomy. And children are not in one size. You have a preemie, you have a newborn term, you have neonates, and you know, smaller children. So it's an entire range. and you have to understand the anatomy and physiology in that range. Now, smaller children would have higher cardiac output. They would basically the local anesthetic would be absorbed faster, moved faster, metabolized faster. The liver and kidney are also not great in smaller children. They are just developing. So there's a risk of toxicity. So you have to really tailor your dose, the concentration according to the age and the kind of block you're trying to give. Now, especially be careful when you're giving infusions. Single shot local anesthetics are still okay. When you're giving the infusion, be very, very mindful of what concentration and what volume you're giving, because there's a cumulative effect, and the literature is still very limited on the infusion, continuous epidural infusions. So it's better to be on the lower side and titrate and increase as per needs, or go multimodal and use different modalities for pain relief along with regional. Now, the better thing in smaller children, especially infants, is that the sympathetic system is not so developed. So if you're giving a spinal or a caudal, you would not have a typical hypotension as you see in adults. So there's no, even if you've not given IV fluids, it's all right. There'll be no problem. Now, as I said, the equipment is different. So in central neuroexablon, we have 5 centimeter long, both spinal needles and epidural needles, and the gauge is also less, they're thinner, so that you have a better grip and you don't inadvertently go too deep. Even the epidural catheters are different. They're polyurethane, they coil. So because of safety purpose, a lot of institutes they practice a caudally inserted thoracic epidural catheter. But in smaller children, they're so soft, the polyurethane catheter, they may coil. And when you insert too much, they coil too much. And when you pull them out, there's a knot. So then you are stuck with a knot inside. So, be careful. If you have to give a thoracic epidural, then you give either lumbar or thoracic, not caudal. Try to be closer to the dermatomes you want to address to. Safety is another issue. So if there's a spinal cord and the distance from the skin to spinal cord is very less, so be very careful when you're choosing an epidural, thoracic or lumbar for a small child. It should be totally under supervision with a lot of practice, or choose something else. I'll come to that, what to choose. Test dose for epidural you can give, but it's controversial because you will be giving under GA, so there'll be confounding factors. So personally, I do not give test dose. I'm just careful that it's not in a vessel. Now, peripheral nerve blocks, they are quite similar to adults broadly. And ultrasound has made a complete change when it comes to peripheral nerve blocks. They can be given single shot or continuous infusion. As I said, catheters are available for peripheral nerve blocks also. So you have epidural catheters and you have peripheral nerve block catheters for children. And they have, since they're so thin, they have guide wires in it, and they are ultrasound enhancing as well. So you can really choose the appropriate size and use them for continuous peripheral nerve blocks as well. Now, the question is how to decide what to give and how to give. So what are the factors that I'll be careful of? One, what's the age of the child? So the moment I know the age, I know which block is safer, what drug to use, what concentration to use. In a bigger child, I can be more liberal. Then I have to see whether I want intra-op analgesia as well or just post-op analgesia. So again, I will choose the concentration accordingly. And I'll decide if I want a long post-op analgesia, I'll choose a continuous technique. Now, another important thing is whether you want a sensory or a motor block. So if I want only a sensory block, I would probably choose a, say, ropivacaine. If I want the motor block, like in orthopedic surgery, sometimes we want the motor block. We do not want to ambulate the patient. So we would maybe choose something like bupivacaine. Now, the most important is the level of monitoring available in your hospital. What about the night staff? If I'm putting in a catheter, I am very careful of what my nursing care is like. What's the status? No way the infusion should be connected to the IV because I'm giving local anesthetics. We are mindful of similar things in adults, but in children, the margin of safety is very, very less. So you have to be obsessed about the level of monitoring. Now, so the biggest question now is whether you choose central or peripheral nerve blocks. Now, central blocks are very effective. We all know that. An epidural, a caudal are very effective. But they have a risk involved with them. So with the ultrasound coming in and people getting used to ultrasound, peripheral nerve blocks, everybody is moving now from central to peripheral, more so in children than in adults. And now you can place catheters and you can have a peripheral, you can have efficacy as well as safety. So I would prefer a peripheral nerve block compared to a central nerve block. Now, as I said, ultrasound guidance is the game changer because here now I will hit where I want to hit. I can do some hydrodissection. I can reduce the amount of drug because I'm very precise when I'm doing the block. I can use facial planes like the TAB block and the ESV block. I can reduce the complications because I'll definitely avoid touching the nerve, going into any vessel or crossing the pleura, so I'll be careful. Now, caudal, which over the years we've all given blind caudal blocks and we thought it has been great. But now, since the time we've started using ultrasound, just put the probe there and it gives us so much of reassurance that we're in the right place and we can see the spread. And in cases where there's a sacral dimple or there's a hair tuft, which is not uncommon, there, if I put a probe before the procedure, it helps me decide, should I go in? Is there a spinal dysraphism? So it helps me decide whether I should give a caudal or it's not safe to give a caudal. So there's a lot of safety attached to using the ultrasound probe. Just putting a probe makes a way change in the whole thing. Now, but you should have the right size probe. If you have a big probe and a small child, it doesn't work. Try to be in plane, try to identify the structures correctly, and do a lot of practice on of needle tracking before you actually put a needle into a child. That's the suggestion. I mean, that's how we've all learned. This is an article I thought I'll share. This is a very recent one. And they've tried to put some core blocks into place. As you see, caudal is in the center. So this is the commonest block we all give. And with the ultrasound, we can add safety to it. We can put additives and make it really work very well. There are other blocks here, dorsal penile, QL, sciatic, rectus, but I'm not sure I would place them as my plan A blocks, plan A and plan B or the advanced blocks. So this you must figure out yourself. This is a Western data. So I think we should figure out ourselves that which are the blocks we are comfortable with. Like personally, I would prefer an erector spinae over a paravertebral or a SAP or a QL because I'm more sure about the landmarks here. And I think it's a plain block. I'm not worried about any vessel coming into my way or a nerve injury. I would prefer a supraclavicular here because I'm more comfortable there. So you choose, basically you have a plan A and a plan B block. They're just some pictures. I don't want to go into how to give a block, but the same blocks, what I'm trying to show is the same blocks as you give in adults can be given in children very safely. especially the spatial iliaca block, you can give under GA without changing the position in supine. It's a suprainguinal position. QL block, they've been described in various positions. So I don't want to change position sometimes, so I may choose something else. Now, this is a typical caudal block. You see here, the drug spread has to be here. If, when we started putting a probe there, we found that sometimes a needle was coming here and the spread was here, or it was going too much deeper and the spread was here, and no wonder it was not working and there was tachycardia in the procedure. So when I put the probe, I put the needle and I put the probe, I'm very sure and very confidently I can tell the surgeon I'm in, And I just want to share this video. This is an erector spinae catheter. This is the catheter, coming. This is the needle, and this is the catheter coming in. So this was just, I think, an 11-month-old baby for thoracotomy. So I thought I'll not give a thoracic epidural. I'll prefer a erector spinae continuous catheter, and the child could be extubated so easily and was absolutely pain-free. Pudendal is another block I found very useful. Here is the pudendal artery, which you can see easily pulsating when you put the probe. This is the sacrum, and this is the needle coming in. So the landmarks are very simple, it's quick and easy. So choose blocks that are quick and easy, and you can master them, give them safely. You won't take too time, and they're very effective. This is for the cleft lip and palate. So not my first choice, but yes, blocks are available. Blocks are available from head to toe, but you choose what you think is safe and you can give it safely. These are the dosages. The ESRA and the ASRA guidelines have laid down dosages for children, and follow the dosages, but you need not match these doses. I give much lesser, depending on my requirement. So these are just guidelines. Don't cross them. Put additives. There are lots of adjuvants you can use. So depending on the post-op nursing care, depending on how the availability, the dose, the comfort, you choose your adjuvants. There is no compulsion of overdoing regional anesthesia in children. Safety is the most important part of the whole approach. And there have been several, this French study, the Pediatric Anesthesia, Regional Anesthesia Registry, the UK audit, they've done thousands of, they've studied, and there has been no permanent damage. The rate is very, very low. But that doesn't mean that I let my guard down. No, I am more worried about safety than efficacy any day for any child. So I have to be very, very mindful of what I'm doing, how I'm doing, because I cannot afford to have a nerve injury or a systemic toxicity. It's all under GA, things are masked. So first I should prevent, and if at all it happens, I should be prepared. So prevention and preparation are the two important things. When it comes to pediatric regional anesthesia, there are certain controversies, especially I talked about test dose, then about the air and saline. So we give air, but use very little air. Saline is preferred any day, but if you're using air, use very small volumes of air to do the LOR. Acute compartment syndrome is something that is very important to understand when you give regional. If you give a very nice sensory and motor block, then you may mask the effects. So you have to discuss. You have to discuss with the surgeon or the surgical team. So as you see, there are lots of things that you need to know. It's the same like adult, but yet so different. It's same, but different. So you need to understand the anatomy, the physiology, the pharmacology. If you use ultrasound, definitely use ultrasound. I wouldn't do without it. Prefer peripheral nerve blocks over central. in peripheral, you prefer facial plane blocks over other blocks, prevent nerve injury, prevent drug toxicity by using minimal concentrations, minimum volumes that require, and insist on monitoring and keep the acute pain services active in your hospital. Only and only then you justify the use of regional anesthesia in children. That's all from my side. Thank you for the patient hearing, and we would love to take questions later. Thank you.
Thank you very much, Dr. Rakhee. There is so much literature available on pediatric blogs, and there's so much material online. But your talk was so lucid, it was so simple, and such wonderful practical tips. I'm sure the listeners have benefited a lot, and we will definitely take the questions at the end of the 3 talks. Now, as Dr. Rakhee has very rightly highlighted, regional anesthesia is actually the cornerstone of pediatric anesthesia pain management. Not only is it very safe, but they're very easy to learn. And with the advent of ultrasound and its easy availability by the bedside, peripheral blocks have taken over and central neuraxial blocks have taken a backseat. But in spite of that, there are certain situations where a regional block may not be the answer. What about the children who are on anticoagulants? What about the children who have surgeries for regions where a block either cannot be given or is not relatively safe? You may have many other situations where you would want, in addition to a block, some form of multimodal analgesia, because this is because of the growing appreciation of the role of patient safety. The importance of multimodal analgesia has really multiplied because of this current focus on eliminating unnecessary perioperative risks. So we have a very learned teacher and a distinguished member of the fraternity, Dr. Navdeep Sethi, who would be telling us about all the other modalities of regional anesthesia that we can use in children other than peripheral nerve blocks. So allow me to introduce Dr. Sethi. Dr. Sethi is currently the senior consultant and head at Yashoda Super Speciality and Cancer Hospital, Ghaziabad. He has many publications in national and international journals. He's the recipient of Dr. Ambadekar Award as well as the ICA Medal for first position in MD Anesthesia from Pune University. He's been trained in pediatric anesthesia from All India Institute of Medical Sciences, Delhi, and New Children's Hospital, Sydney. He's the current vice president of the Delhi chapter of IPA. He is the governing council member of RSACP, a teacher and an examiner for MD, DNB, and DM students. He was formerly the head of AFMC Pune and Army Hospital Research and Referral Center at Delhi. He is a reviewer of many journals and was awarded the fellowship of IPA in 2018. So we have Dr. Navdeep Sethi talking to us about modalities beyond regional anesthesia in the management of pediatric pain. Over to you, Sethi sir. Sethi sir, you can start your screen sharing.
Yeah, okay. You will have to stop your sharing.
Yes, I did that, sir.
Okay. Just let me know when you can see.
Yeah, we can see your slides, sir.
Okay, and you can hear me too?
Yes, sir, loud and clear.
All right, thank you. Thank you indeed for those kind words, Dr. Ranju. I bring you greetings from Yashoda Super Speciality Hospital in Ghaziabad. Acute pain relief beyond blocks is the topic I'll be dealing with today. As adults feel pain, so do children. Pain relief, in fact, is a fundamental human right. As rightly brought out by even Dr. Ranju, in the International Association for the Study of Pain 2010 Montreal Declaration. In fact, neonates feel more pain than their adult counterparts. In spite of all this, unfortunately, more than 40% of pediatric patients suffer from moderate to severe perioperative pain. So what are the adverse effects of this pain? Well, besides patient suffering and family dissatisfaction, it may lead to dysrhythmias, atelectasis, pneumonia because of respiratory issues, ileus and anastomotic failure, an increase in the stress hormones, and a reduction in immunity, which prolongs recovery and leads to increased cost for the hospital. And finally, it may also lead to persistent post-surgery pain beyond 3 months. So acute perioperative pain may be in the preoperative period, like in cases of trauma, malignancy, infection. Intraoperative pain is usual. We generally give GA in babies and children and assume that we have given adequate pain relief. And postoperative pain, invariably, or rather usually, there is inadequate relief. So severe pain is present in which all surgery? Well, in thoracotomies, abdominal surgeries, extremity surgeries, perineal surgery, and certain surgeries where blocks may not entirely work, like spine fixations, maxillofacial surgery, trauma, and burns. Just some glimpses of severe pain. So what are these surgeries? Well, you have burns and trauma, craniosynostosis, large spinal lesions like sacrococcygeal teratomas extending into the lumbar region, and maxillofacial injuries and lesions. So perioperative pain relief, the essentials, relief of acute pain is integral to enhanced recovery after surgery. It entails multimodal analgesia with drugs which are synergistic so that the side effect of each drug is less and there is opioid sparing. And we invariably try to combine with regional blocks, either central or peripheral. And multimodal analgesia must be preemptive. That means IV drugs or regionals given before the onset of pain, which prevents CNS sensitization and pain amplification. This not only reduces post-op pain, but prevents chronic pain. So in the first step for perioperative pain management, you must recognize the presence and extent of pain, as rightly brought out by Dr. Anju. We must treat and provide sufficient analgesia by multimodal preemptive techniques with the use of perioperative drugs, regional blocks, and must monitor for side effects. Regional blocks have been dealt with. I shall deal primarily with perioperative drugs. So before I start pharmacological, just a word about non-pharmacological modalities. Especially in small babies, you can resort to swaddling, and in the bigger baby, if you reduce pre-op anxiety, it has been shown that the perioperative pain is less. So hence the importance of giving pre-medicals. Pharmacologically, we can use drugs. Opioids is our mainstay. Others like NSAIDs, acetaminophen, alpha-2 agonists, ketamine, they are part of multimodal techniques. And local infiltration is a procedure often neglected, but is very useful. The WHO pain ladder, the WHO pain ladder, is basically goes from simple analgesics to strong opioids, depending upon the extent of pain. The site of pain, opioids and alpha-2 agonists address at the central level, local anesthetics, opioids and alpha-2 agonists at the spinal level, local anesthetics again at the peripheral level, and the NSAIDs and local anesthetics also act peripherally. Paracetamol is largely central. So paracetamol is the first line treatment in mild to moderate pain nowadays and is definitely opioid sparing. It inhibits CNS prostaglandin synthesis. The dose has now been revised from the earlier 7.5 milligram. Now, even in late preterm and term neonates and infants, the dose is up to 20 milligram per kg loading and 10 milligram per kg 6 hourly. In children and adults, 15 milligram per kg 6 hourly can be safely used. Rectal is often neglected but very useful. In preterm, we can give up to 45 milligram per kg per day. And in term babies, we can give up to 60 milligram per kg per day in divided doses. Be careful where there is liver damage. NSAIDs are again very popular as multimodal analgesics, more in adults and less in children. They block the cyclooxygenase COX-1 and 2 enzymes, reducing prostaglandin synthesis. Rectal diclofenac is a neglected modality which can safely be used up to 1 milligram per kg 8 hourly in pediatrics. Intravenous ketorolac, where available, 0.5 milligram per kg can be used 6 to 8 hourly. However, NSAIDs are viewed by suspicion by most surgeons because they may be implicated in GI ulceration, bleeding disorders, renal dysfunction, asthma, allergy. Hence, their use is by and large in pediatrics restricted to rectal suppositories. Opioids are the mainstay in moderate to severe acute pain. They act via specific opioid receptors in the brainstem, spinal cord, and peripheral afferents. As per recent studies, opioid receptors are now primarily of 5 types. They are G protein coupled, as you all know. They may be mu 1, 2, and 3, kappa 1, 2, and 3, delta 1 and 2, nociceptin, and zeta. The erstwhile sigma receptor is probably a mediator of psychotropic drugs. So opioids may be given perioperatively, even preoperatively. In fact, they may need to be given in severe trauma. The drugs commonly used in the acute phase are morphine and fentanyl, which are strong mu agonists, and tramadol, which is a weak mu agonist. The intravenous dose of morphine, as you all know, is 0.05 to 0.2 milligram per kg per dose, given 2 to 4 hourly. It can be given as an infusion. Fentanyl is 0.5 to 1 microgram per kg per dose, 1 to 2 hourly, and can be safely given as an infusion, provided we monitor. Tramadol is largely confined to the post-op period, 1 milligram per kg, 6 to 8 hourly. Ramifenterlin is now recently available, but I will not be discussing too much because we are just now getting experience in its extensive use. Patient control analgesia includes conventional PCA pumps and the disposable pumps. Well, this is a useful modality, but primarily in the older child. Just to escape for our younger colleagues, if you give intermittent drugs intravenously, then you have peaks and troughs of drug action. If you give a continuous infusion, it takes about 4 to 5 half-lives before you have therapeutic drug levels. However, if you give a bolus followed by a continuous infusion, that's ideal, and you can quickly achieve therapeutic drug level. PCA, the advantage is rapid titration, reduced breakthrough pain, allows the patient to reach their minimum effective analgesic concentration. They have reduced analgesic requirements and possibly less monitoring. However, patient control analgesia pumps can be programmed and must be programmed for both the bolus dose, the lockout interval, and background infusion for safety purposes. The control in the PCA pumps can be with the baby if he is more than 6 years old. However, the nurse and the parent takes over beyond that age. The standard PCA dosing is morphine 0.02 milligram per kg bolus and hourly, fentanyl 0.5 mics per kg bolus and hourly, with a lockout of 10 to 15 minutes. As you know, opioids don't have a ceiling effect or a maximum dose, but must be monitored closely by respiration and SpO2, especially for respiratory depression, which is the most important side effect. And just a caveat, you must avoid systemic opioids if the patient is on PCA, that is epidural opioids already. So what are the opioid side effects? Well, we all know the the common side effects, nausea, pruritus, constipation, urinary retention, ileus, tolerance, sedation, but the most serious one remains respiratory depression. Normally, the common side effects like nausea we may prevent by giving ondansetron or dexamethasone. Respiratory depression, a point to remember, is usually preceded by sedation and meiosis. So if your baby is very sedated and not responding even to slight stimulation, you must suspect that he may stop breathing and take action accordingly. So you must stop further opioids if your baby is deep, stimulate, give oxygen, monitor his SpO2, and shift to PaCU if you haven't. The dose for naloxone, which is the specific antagonist, is 0.5 milligram in 1 ml ampule, and the dose is 0.01 milligram per kg IV. Repeat every 3 to 5 minutes. That means you dilute 1 ampule in 10 ml and keep giving 1 to 2 cc every 3 to 5 minutes. You can go up to 0.1 milligram per kg if there is no effect. A caveat, the action of naloxone lasts for maximum 1 hour. So monitor after that even for respiratory depression, which may recur. Dexmedetomidine is a selective alpha-2 agonist acting at the presynaptic adrenergic receptors in brain and spinal cord. It's an analgesic, sedative, a sympatholytic. It's a useful and a popular adjuvant now in general anesthesia and regional anesthesia in children. Often neglected is the intranasal use of dexmedetomidine. It can safely be given 1 to 2 mics per kg, 30 to 45 minutes prior to the GA. It accentuates the perioperative analgesia and sedates the baby, allows easy separation from parents. Intravenously, the dose is 1 mic per kg given over 10 minutes, followed by an infusion of 0.5 to 1 mic per kg per hour. This also has a very strong perioperative opioid sparing effect and also reduces post-op agitation in babies while preserving respiration. Ketamine, once very popular, is an old phencyclidine derivative and NMDA antagonist. It's popular as a dissociative anesthetic. It has no respiratory depression, but its psychomimetic side effects are limiting side effect. It's not only a sedative, but also an analgesic, amnestic, and sympathomimetic. It is now finding a resurgence in both pediatrics and adults. As a low-dose analgesic, a bolus of 0.25 to 0.5 milligram per kg, followed by an infusion. And an IV induction agent, it is still popular in rapid sequence intubations and trauma, 1 to 2 milligram per kg. It's also popular as an adjuvant for short GAs in children. The drugs like gabapentinoids, magnesium, and lignocaine, now popular in adults, are still not much used in pediatric anesthesia, and there are not many studies about their use. Local infiltration analgesia is often missed, but again, very useful. That is, surgical site infiltration at the end of surgery is now a vital part of the ESPA, European Society of Pediatric Anesthesia, post-operative pain guidelines 2018. It's simple, safe, inexpensive, and should be more used. You can safely give 0.25% of bupivacaine, referred to bupivacaine, before skin closure, and may be given even as a continuous wound infusion if feasible. However, you must watch for the total dose of local anesthetics and prevent local anesthetic systemic toxicity, which has already been discussed. So what is the carry-home message? Perioperative pain is unfortunately widespread in children. We must recognize and treat early. Analgesia needs to be preemptive and multimodal. Systemic analgesics, often an integral part of GA itself, are the mainstay. Regional blocks, extremely useful and must be used maximally in conjunction. However, monitor closely for the side effects of your drugs and of your regional analgesics. Thank you. If you looked after your patients, they'll be comfortable in their mother's arms post-operatively. Thank you once again for a patient listening.
Thank you very much, Sethi sir. For all those who believe that parenteral analgesics in children started and ended with paracetamol, your talk will definitely be an eye-opener. we've had a very comprehensive and exhaustive coverage of the topic, but I wish to just put it all together in perspective and take it a notch higher from the academic platform to an extremely practical, clinical-based platform. So for all the speakers here, I have a few cases where I would like their inputs that if they were doing these cases, what practical pain relief management would they do? So I have the pictures here. Let me just share my screen. Right, visible?
Yes, ma'am.
Yes.
Right. So on the left-hand side, you can see a cleft lip, which has just got operated. This is a 3-month-old child, approximately 5 kgs in weight. And on the right side, you see a cleft palate, which is, the child is now 2 years old and approximately 12 kgs in weight. So Dr. Rakhee, do you think both these cases are amenable to blocks? And if you were to do them, what will be the optimum management strategy for these patients?
So both, yes, blocks can be given. For the lip, it's the intraorbital nerve block. And for the palate, you can have several nerve blocks, but greater palatine is what is usually given. And earlier we used to give, but in the current practice, I have stopped giving, to be honest.
Yeah,
Second, the surgeon
actually,
can give. Surgeons usually give the block for the palate because the mouth is open, they're already there. So, and they know the anatomy, they know the nerves to be blocked. So palate typically our surgeons give. Lip, the intraorbital block can be given intraorally or extraorally, but the problem is if there's a hematoma, it looks very gory post-op. So I have stopped giving intraorbital nerve block, but yes, you can give. Why not?
If you were to give intraorbital block to this child who's 5 kg, how much volume would you use and what concentration of bupivacaine do you recommend?
So intraorbital, you don't need volume, you just need half to 1 cc.
Right.
You know, and you could give 0.25% of bupivacaine, you know, or if you're giving ropivacaine, 0.2% is good enough. So the volume wise, both need very small amount of volume.
Right. So intraorbital works actually very well and produces quite good pain relief. But palate is, of course, a different story, particularly bilateral large palates with mucoperiosteal flaps and, you know, lateral relaxing incisions involve a lot of dissection, and any handling of the periosteum is extremely painful. So, you know, I also used to give suprazygomatic maxillary nerve block, but I have stopped that now. Are these blocks amenable to ultrasound? Can you
Yes, they are. Yes,
give greater palatine under ultrasound guidance?
You can, but you know, you have to have practice. So you have to see what's the risk benefit, and time is also important. If something that the surgeon can give so easily and so quickly, why should I waste time, you know, in exploring a nerve and then I'm not sure? I won't choose that. But we've started adding dexmedetomidine IV to both such cases, and that brings down a lot of requirement of intra-op analgesics and the need for blocks. So
because
that has changed.
You were trying to say that these blocks are, one, difficult to give, not very safe probably, and the option is for the surgeons to give them. So what does the anesthetist do in addition? Dr. Sethi, do you have anything to add to these palates, which you probably get done very frequently?
Yes, ma'am. If it's a cleft lip only, then generally what I prefer doing is giving 2 mics per kg of intranasal dexmed.
Right.
That's about, so in this baby around 10 mics. So if you dilute your one ampule of dexmed into 10, then 1 cc of that.
You want to give this dexmed post-operatively, sir?
No, no, I give it pre-operatively. So that because it's a cleft lip, and then I don't give it intravenously.
Okay, so it provides sedation in addition to the analgesia.
Sedation and perioperative at the same time ensure the baby gets up in time.
Right.
And then I use, you know, intra-op I use fentanyl I always give a Voveron suppository. So in this baby, I'll give a 12.5 milligram suppository and paracetamol 15 milligram per kg.
Right. You will give both the things, the IV paracetamol as well as the diclofenac suppository.
I always use, I mean, I personally give both together.
Right.
And because I don't find a contraindication, and our surgeons are also happy with it because the child is very happy in the post-operative period.
Right. And what about the palate?
Yes.
It's so painful, and you have this howling child in the post-operative period who's unable to feed because of the pain, and more importantly, because of the crying. There is so much of tension on the sutures that it becomes a nightmare for the surgeons also.
Absolutely, ma'am. You're absolutely right. The only catch with this is because it's a palate, so the intranasal Dexmed is not a practical option.
Right.
So what I generally use is I invariably give intravenous Dexmed, ma'am, in addition to our fentanyl. So that's the dose I've already brought out. Initially 1 mic per kg after induction, given over 10 minutes, and then 0.5 to 1 mic per kg per hour. I stopped this half an hour before the surgery, ma'am.
Okay, so would you recommend this fentanyl in the post-operative period also, besides the intra-op period?
Yes. So cleft palate is a little tricky because if the child is a difficult airway,
yes, that's one. There is a chance of post-operative obstruction because the area gets reduced, and most of us from large government hospitals do not have very high level of monitoring because it's all resident based in the post-operative. So would you recommend that these children be subjected to IV fentanyl infusions in the post-operative?
No, certainly not. That's why, if you're in a government setup and you don't have a PSU or an ICU care, I would suggest use Dexmed intraop and fentanyl. And in the post-op period, continue your Voveron suppository and paracetamol. Along with that, you can use ketamine boluses of 0.5 to 1 mic per kg very safely when the child is very agitated. And in addition, tramadol can be given 1 milligram per kg, 6 to 8 hourly, again very safely. I would avoid using morphine or fentanyl in patients with difficult airway or an OSA.
Right. So you would recommend a combination of all these drugs.
Absolutely, multimodal
together.
And opioid sparing as far as possible.
So that's nice. Anju, what would you recommend that the resident look at when he goes to see these cases in the post-op? Because you've done them and then they go to the ward and you also go home, and all the monitoring from your end, from my end also, is on the phone. So how would you recommend that the resident report to you? What should he see exactly when he's seeing these patients in the post-op?
See, as we've discussed, if in the post-operative period you've given this child a bolus of fentanyl because he's, crying and he's very, very agitated, then you might want to keep the child in the PSU and you shift the child to the ward once the child is calm and quiet and he's no longer getting any opioids at least. So when I tell my resident to go and see the child, then we the scale that we could apply here is something like the FLAC scale. Okay. Which is good for pre-verbal children. I think after today, perhaps I will tell my children. We do tell our residents to go and see how is the child. Is the child restless? Is the child sleeping? What do the parents say about the child? Is the child crying? These are things that our residents normally follow up. But if we want, we should now start implementing. We should all implement some scales for use in our hospital. And a child of this age, both of these children, in fact, they can be very easily evaluated using a FLAC scale. So the resident can go and see how the face of the child is. Is the child calm? Is the child screaming? Is the child grimacing? Is the child comfortable? Then they can see the leg activity. The child is sleeping, his legs are relaxed, or he's drawing up his legs, he's kicking and he's in pain. So we actually do see this, but we don't do it in a formal, in a scoring system. Then A in FLAC is for activity. So if the child is sleeping, lying quietly, it probably means he's pain-free. But if he's kicking around, then again, crying, what is the type of cry? Is he not crying? Or is he whimpering and crying a little bit? He might be having a little bit of pain. Or is he screaming and shouting? That means he is having pain. So, of course,
Yeah, so FLAC scale you think is a good option?
I think, yes, as I said, I think the FLAC scale.
Two things which I've noticed in my practice of so many years is, one, they don't do it pre-operatively, The only assessment which starts is post-operatively when they run to see the patients after the surgery. So this assessment must start in the pre-op. They must see the child in the pre-op, tell the mother that what all they will be monitoring and how they would want the mother to assess the child in addition to them and the nurse. The second thing which I've noticed, Anju, is that occasionally it happens that a different person's done the pre-op assessment, and it's a different person, a different resident who goes to see the patients post-operatively.
That is true, Dr. Anju, but in the pre-op, the child is going to be fine. There's no pain in the preoperative period. So there is actually no need to do a baseline assessment before surgery. Okay. It's an elective surgery. There is no pain. And these are all behavioral variables that are going to come due to the presence of pain.
But so it would help, do you think, that if it's the same person who's seen the patient preoperatively and again assessing it post-operatively? Because with residents, you have, a change of guard in the theater, somebody's not turned up, some replacement or somebody else on duty is sent to see the child. They've never seen the child preoperatively.
That is why I think that it's time that we put these scales into place, and these scales have been proven to be reliable. So there will be less inter-observer.
So I think we can make a move of, trying to chart this as part of the vital parameters. You yourself said it's the 5th vital sign. So I think it's time to put it in the assessment sheets, in where the sister is charting the fever and the urine output and the pulse rate and the heart rate. There, probably pain score should now mandatorily be added for assessment of these children.
Because anyway, these are the things that...
Yes,
If I may add here, especially in these two cases, in the immediate post-operative period, that's the PACU, the recovery room time, there's a lot of overlap between emergence and pain.
Yes.
So we, especially oral surgeries, the emergence is too much. So we need to differentiate between the two and treat accordingly.
Yes.
Later, yes, of course, it would be the pain, and that's where the dexmedetomidine really helps. It kind of takes care of both very well.
And the other thing I usually like to emphasize to the residents who are watching these cases is to watch these children and then watch them again and assess them after the intervention has taken place. The assessment should follow the intervention.
Yes, after every pain intervention.
Absolutely.
Whether it's a pharmacological or non-pharmacological intervention, like like we've been told, swaddling or giving sucrose or giving any non-pharmacological intervention that might help in the mild pain. Supposing the FLAC score is something like 2 or 3, then maybe a non-pharmacological intervention is enough. Maybe the kid is just hungry, So maybe we need to feed the child.
Right.
So we have a paper in our case sheet for all children about the pain. It's mostly nurse based, but we do our own, so we also have. So there are different scales as per the age. So we have chosen a few. You can't have 40 scales, so we have chosen 3, 4. It's just a 1-page, both sides scaling. So appropriate size, and that scaling is done. The scoring is done, every day. Twice a day, at least.
That is something that needs to be implemented in all hospitals where pediatric anesthesia
you can share a copy if anybody wants.
Right. Okay, so let's take the next case. Now, this was a meningomyelocele I had got done a couple of weeks back. This is a 1-month-old child, 3.5 kgs in weight, and look at the extensive incision. I have never seen such a huge incision. It's a big flower-shaped incision all across the back and covers from the thorax right till the sacral region. Now, if we to get this case done, how would you manage this pain? And particularly because it's a meningomyelocele, I believe Dr. Rakhee, central neuraxial blocks may not be a very good option. Here they'd handle the cord, the CSF may be dripping, you really don't know what's happening. So, Dr. Rakhee, what would you do for such a case?
So, of course, intra-op opioids. Second, you can infiltrate, but the volume may be very high. So, you have to dilute your local anesthetic. I would prefer levobupivacaine or ropivacaine. We've actually stopped using bupivacaine because I feel the cardiac toxicity is too much of a threat that I don't want to stress about. So, preferably a safer, levo or ropin.
Right.
And here the volumes, as I can see, it's huge.
It's
So
huge.
first-
It's huge because the
so-
incision was so large, and because they had so much of
Yeah.
tissue handling, and central uraxial blocks were not an option here because the incisions were so wide and involving so many tissue planes. We were unable to give any erector spinae or
No, we can't. There's no point.
Yeah.
So even
I think
infiltration, we
doctors-
monitor when the surgeons infiltrate large volumes.
Yeah.
I'm very particular because it has to be during withdrawal of the needle. If they inject the LA, it's very different rather than withdrawing the needle, and while withdrawing you inject. So, that's another step we do to prevent last.
Right. Because this was just 3.5 kgs, and with so much of incisions to be covered, it's very likely that you will exceed the volume recommended. Sethi sir, do you have any other option for this child for whom we cannot give blocks?
Yeah, one of course, which you were mentioning, the local infiltration. Only thing is we'll have to go down to 0.1% of ropivacaine. And in this baby, I see 3.5 kg. So that means I can give about, my mathematics is all right, around 15 ml of 0.1% maximum of ropivacaine. If I take, say, around 3 milligram per kg.
For
So
peripheral infiltration, would you encourage the use of an additive?
in the
With the local anesthetic.
well, there studies are plus minus for a local infiltration. It's a moot point, ma'am. Some people, they like to add. I really don't know how efficacious it is, but I will definitely give some infiltration.
Right.
I know if they will work. Secondly, a point I just like to make is, when we pre-medicate these babies, especially if you use Dexmed, if you use dexamethasone routinely, that also helps to potentiate the analgesia. And of course, in this baby, as already brought out, we'll have to use multimodal, including liberal use of fentanyl and
Yes.
your Dexmed.
Yes.
I presume we would like to extubate these babies because there's no airway issues.
Yes.
So, so morphine,
but meningomyelocele are tricky because there is a lot of involvement of other systems, skeletal, urological, muscular, CNS, so many other systems are involved. The neurosurgical treatment is extremely complex. So your extubation, and they will depend on a lot of other things, but that notwithstanding, irrespective of whether there is other involvement or not, pain relief becomes a must. And since blocks are not very simple in this, probably a rectal suppository together with paracetamol and an infusion of fentanyl would probably be helpful to mitigate the pain.
Fentanyl infusion, ma'am, and you can even give a tramadol if fentanyl is an issue with monitoring.
Right.
Though I think monitoring is a must. Then at the very least, tramadol 1 milligram per kg, 6 to 8 hourly needs to be given if you're wary about using fentanyl. So
Right.
fentanyl would be my first choice.
Right. Now, this is another case where blocks cannot be so easily given, like we've talked about in the palate. This is a child with a melanotic neuroectodermal tumor of infancy where a hemimandibulectomy was done. So, Rakhee, any blocks here?
No, I think this kid will definitely go to the ICU. Pediatric ICU. I'll run an infusion of fentanyl along with paracetamol and maybe an NSAID age appropriate. He's 3 months. I'll avoid NSAIDs. I will prefer opioids, clearly.
Oh, right. So, you have any other?
Yes. No, the only thing is, instead of fentanyl, I would prefer using morphine in this baby because, see, there's an airway and he's got a nasal tube. So I know he'll be by and large comfortable post-operatively, and we would need to ventilate him at least for 6 to 12 hours minimum. So I think morphine infusion is the way to go in this baby in the post-op period. Right. With the, dexamethasone initially.
Our problems become much easier when you know that the child's lungs will be ventilated and the airway will be taken care of. Correct. So we can safely give opioids in recommended dosages with adequate monitoring. So fentanyl or morphine, whatever is the choice of an individual person, I think opioids, along with a little bit of paracetamol to complete the multimodal analgesia aspect, and to ensure that there is a lot of anti-inflammatory action of the NSAIDs and acetaminophen, whatever you are giving, in addition to the opioids. So probably an IV infusion would be the best for this child in the post-operative period. Right. What about a neonate with a TEF for thoracotomy? Rakhee?
So we can give them lots of options, erector spinae, single, a bolus dose. It all depends whether you're ventilating or not ventilating. If you're extubating, if the plan is extubation, go ahead, infiltrate the incision, because thoracotomy incision is very painful.
Very painful,
So,
right.
So either local infiltration plus minus a block. You can give paravertebral, you can give erector spinae. Erector spinae is my favorite, so I would choose that. Or nothing, or sometimes no regional, just infiltrate. And like Sethi said, there's so many other IV analgesics. Go ahead and give that, because mostly they are ventilated for a day.
They will be
so mostly they are ventilated. So because this baby is just 1 day old,
yes.
simply putting a needle just because I can, I would choose not to.
Right. So is it advisable to use catheters in the facial plane blocks for these children, or you just believe in a single shot?
No, so this is a 1 day old. There's a lot difference. In a 1 year old and 1 day is a huge difference. In 1 year old, we have put catheters for thoracotomy. For 1 day old, I have stopped doing these kind of things. My practice has changed in the last decade, where initially I used to do a lot of blocks, and now I stop myself from putting needles where I can do without them in certain cases.
The good old thoracic has gone out of fashion, Rakhee?
No, not at all. Not at all. But I would not prefer a central neuraxial here. It's not safe, simply because now I understand the risk benefit. The risk, I feel, is more than the benefit. When I have options, why not?
Okay.
I would choose options that
there
are
was
less
a time when I was a resident where we used a lot of caudal morphine for these children. Does that still have a role? We are assuming that this child will be ventilated, he'll be taken care of.
We still do. We still
pain
do.
relief is so good that
yes, we still do. We still do caudal morphine, and whenever we do caudal morphine for a 1 day old, I check where my naloxone is.
Yes, we do that. We do that, but since the child
will very effective.
Yes,
very
will remain in the NICU, and the lungs will be ventilated, the airway will be taken care of. The monitoring is quite intensive. So I have noticed that occasionally when you are not very sure with the blocks, caudal morphine works extremely well, extremely well. In fact,
it's better to give caudal morphine than try to put in a catheter from caudal to thoracic.
Yes, that doesn't work. I have noticed that doesn't work. It's a false sense of security. Yes.
Yes.
And we have extubated the care of children on table after giving caudal morphine. It works really well.
Yes.
Right. So what about this gastroschisis who comes for a laparotomy? These are sick babies. Many of them may have sepsis by the time they come into you. Coagulation, you really don't know. Dehydration, loss of temperature. These are sick babies. So what about post-operative pain relief in this child who comes to you?
Again, we generally do not touch the back.
Okay.
In this scenario, I would choose not to touch. So, after having done so many blocks, after knowing so many blocks, now you become wary of not doing them. It's so ironical. But this one, again, I would leave it, because this one is definitely going to the ICU. I would prefer opioids and paracetamol, straight and simple.
Right. That's your opinion also, Sethi sir?
Yeah, definitely. It goes without saying. He's likely to have, deranged hematological and other parameters.
Yes,
It's not wise to try to, to poke this baby. I think it's best to go by systemic analgesics.
Right.
And we have multimodal analgesics at our disposal.
Right. So opioids together with paracetamol works
Absolutely.
best. Works best for these babies who are anyway going to the ICU.
Even dexpet infusion can be continued post-op.
Okay. Okay. Fabulous. Fabulous. So what about laparoscopy? Now laparoscopy is taking, a large part of the lists are now laparoscopic procedures, particularly like this child, a laparoscopic appendicectomy was done. So what would be the modality for such a patient who's undergoing a laparoscopy with multiple port sites that can create pain?
So we can give caudals, but caudals do not cover the entire laparoscopy pain. So it's best to first infiltrate the port. So we do it before the insertion of the port. That's the best. But some surgeons do not agree to it. They give it at the end. So you discuss with your surgeons. So local infiltration works. You can give tab block. In slightly bigger children, we could give tab block. But I think after having given caudal and tab blocks or rectus sheath block, which are very easy, very quick,
Yes.
local infiltration is good enough because you will give systemic analgesics as well.
So a tap block, like I usually give a tap block with an additive such as clonidine in doses of 2 mics per kg, together with IV paracetamol, and the child is extremely comfortable. And yes. So for such an older child, Dr. Anju, is the assessment a little different? Just to recapitulate that this is probably, this was a 9-year-old child who had undergone an appendicectomy laparoscopically. So anything different in an older child like this who can communicate?
Older child can very well self-report, so we can use any of the verbal rating scales. That's not a problem. And of course, we have to check the observational signs also, you know, signs of other signs of pain, just to make sure that that verbal rating is accurate. Otherwise, it's relatively easy at this age group.
Right. So even the parents can be coached to watch for signs and then report to you. Is that?
Yeah, parents have to be involved, especially in the smaller children, maybe not in this. And I think one more thing that one has to keep in, if this is a boy, especially the younger boys who are reaching adolescence, sometimes they are, because of cultural beliefs, they are taught that boys don't have pain. So they may, deny pain sometimes. So it's a good idea when you're interviewing the adolescent age group, especially the boys, to do it in private, because they may not, their friends or their cousins or their parents are there, they may not. So there are a lot of things that you have to take into consideration. So maybe have a private talk with the boy and ask him how he's feeling, because he may not want to seem weak in front of his family. Of course, that will be corroborated with physiological and behavioral signs, and you can do a verbal scale, you can do a faces pain scale, you can do a numerical rating scale, any of the two.
Right. The very important point I think you've brought about that, if in general cultural differences can prevent the boys from admitting that they are having so much of pain. So a private session can really be very helpful. A very, very practical point you've brought out, Dr. Anju. So what about these common procedures, inguinal hernia, circumcision, Rakhee? These are very, very amenable to blocks, right?
Yes. So caudal is the time-tested block, which everybody does. It would work for both the cases, but now if you have ultrasound, ilioinguinal, iliohypogastric, which is quite like a tab block, it's quick and easy. You must give a regional block for these cases. For circumcision, you have more options. You can give penile block, but you have to give bilateral. So just be careful of the volume. And you can give pudendal also. But I think caudal is one single shot caudal with an additive. You can put clonidine, you can put dexmedetomidine, morphine, depending on what monitoring you have. And caudal is really...
So in your kind of practice, you're working at a high-end center with so much of facilities. And do you give your caudals under ultrasound guidance, or do you give them blind?
Now we've started, since the time we've started giving, we realized that it's worth putting the probe. So we do it real time now. It just takes 2-3 minutes extra. Earlier, it used to take a long time and we used to see restless surgeons around. But now it's fine. It's quick and easy. So it's two people. One is giving, the other is holding the probe.
Yeah, so you can see the distribution of the drug in real time very beautifully while you're giving the caudal block. Right.
It's worth it.
It's worth it. So Ilisaro fixator, again, I think is amenable to a block.
This is very interesting. Actually, every time we have a tibia and this fixator, we have a discussion. I must tell you that our journals, the anesthesia journals, say clearly, I'm quoting BJ Education, that it's okay to put an epidural catheter, use ropivacaine low concentration, and you have a sensory motor block, it's okay. But the orthopedic journals from the same country, they say no. They would mask, the epidurals would mask the signs of compartment syndrome, especially for this fixator. So it's best. See, there's no point fighting. The best is to discuss with the surgeons, have a protocol. So after a lot of discussions, now we give epidurals, we give 0.2% Ropin. We do not add additives. You know, we let a bit of pain happen so that any disproportionate pain, it's a red flag. Any, you know, away from the site pain, it's a red flag. And any pain in the night, the surgical team is informed. We do not add more analgesia at night without the surgeon having a look. So basically, yes, you are mindful of the compartment syndrome. You can't mask it.
Right. So does a lower concentration of local anesthetic help? In fact, I usually prefer using the concentration of local anesthetic further diluted with the help of an additive. So any sign is not blocked, you know, the analgesia is there, but because the concentration of local anesthetic is very, very low, the signs for a compartment syndrome can be picked up.
Yes, so Ropin 0.2 is a very low concentration, less than 0.2 in a orthopedic
with an
case,
additive, probably if you've given even 0.1 with clonidine, sometimes really helps. Takes away the pain. Yes. So that's
the guidelines, the ESRA and ASRA guidelines, they have mentioned to go low on the concentration and avoid an additive. So we are going by the book so that, you know.
Okay. Okay.
So
and of course, you supplement it with the anesthetics parenterally.
And with systemic, yes. Paracetamol, but any extra requirements, suppose I have said 6 hourly, say 15 milligram per kg of PCM. If it's the requirement is more, then we raise the red flag.
Right, right.
Let the ortho guys see.
What about a supracondylar fracture of humerus? Post-surgery comes for a fixation or a reduction.
So we can easily give brachial plexus block. There are 4 approaches. Whatever you feel is comfortable to you, what you're good at, you can give. But again, see, there's a lot of difference in the approach of surgeons in the private sector and the government sector. And this is not a child. This is not an adult who would give any input later on. So 6-year-old can be tricky, you know. He or she may give, may not give. So in my setup, the surgeons usually do not encourage us to give a block. But while I was in a government setup, we were giving supraclavicular nerve blocks quite regularly. Yes.
Fabulous. So suddenly I'm feeling good that I work in Kalavati Saran Children's Hospital and I can browbeat the surgeons more than you can.
No, it's about a surgical team. It's a shared decision. You know, so if they're not comfortable with the vascularity, with the compartment syndrome, any facial, you know, pressures increasing, so there is no point.
Right. So what about this patient, sir? What would you do in your kind of setup? Also, do you avoid a block?
No, we don't avoid, Ranju. We don't avoid. Our surgeons are quite okay with it. We would definitely give a supraclavicular block plus systemic analgesia.
Okay, great. What about you, Anju? You also do a lot of pediatrics and
we would give
these
a block.
trauma patients so frequently.
We would definitely give a block in this one.
Okay,
we would. I mean, surgeons, we have to, as Dr. Rakhee is saying, we have to go with them and we have to be with them. But, you know, I find it very odd in hypospadias, for example. Now, plastic surgeons don't want to coddle because it causes vascularity.
Yes.
The next plastic surgeon doesn't really bother. One plastic surgeon is so rigid that I can't operate on this surgical site because it's so vascularly engorged. So, I mean, we have to, we are, as you said, a team. So if they're not comfortable, we should not insist.
Regional anesthesia is not about coaching the patients alone. It's about coaching your surgeons also.
Yeah.
It's a shared decision.
It's a shared decision and you should be on the same page.
Yes.
Yeah, for the same type of surgery, one surgeon might be okay, the other might not be.
Hypospadias, I think, is the best example.
Yes, absolutely. I truly agree that when you have a very engorged penile area, the surgeons will throw a fuss, and rightly so, because it becomes
some don't,
for them to
and some don't.
Some don't bother. Yeah, some just don't bother.
Right. So the final picture, this was a patient with a fractured femur after getting involved in an RTA who had come to us for reduction and spica application. So your inputs, Rakhee?
So definitely, yes, a regional has to go with it. So since it's unilateral, I may put an erector spinae block and leave a catheter there. You could do a lumbar plexus or a paravertebral similarly. Yes, it works well, plus some systemic, anti-inflammatories, and it works very well. And give a nice 0.25% bupivacaine with fentanyl or morphine, so that the pain relief is very good. You don't want any mobility, it's not going to ambulate at all.
Epidural or a caudal would also work?
Yes, caudal would work, but yeah, it's best to put a catheter because 3-year-olds, they will need for 2 to 3
No, but
days.
will the catheter not get in the way? Because now that the spica is applied, the surgeons
yes.
are usually
So we put a
apprehensive
lumbar.
about the
We put
catheter.
a lumbar. We don't go till caudal.
Right.
We put a higher lumbar, and they leave. We put our hand when they're putting the spica. So
So that
our
enough
hand
space is
will go in.
available.
Yes, yes. But still, sometimes taking out the catheter does, it's the part of the dressing stays inside.
Yeah.
So you have to retract it.
Dr. Ranju, if I can
Yes.
just mention, in these cases, what we would routinely do is tunnel the catheter.
Right.
Tunnel it upwards.
Yes.
Right. And then continue with do you normally give top-up boluses on a timed basis, or do you use an infusion through the epidural catheter?
Infusion. We use infusion, but if you don't have the infusion facility, the pumps, or you're not reliable, so you can use boluses.
Right.
But we prefer infusion. There is a continuous maintenance. It's good.
Right. So we have
You can-
elastomeric pumps available from Baxter as well as
Yes,
from
you could use
Pinkron,
that.
which work very well for pain.
What is the role of infusions in erector spinae, like in a facial plane block? I thought boluses are the way to go.
Rakhee,
Because
do you want
It
to-
works very
plane
well.
block, it will be,
It works well because the spread is both ways, no? So there is a continuous spread, and here you need only lumbar. For femur,
so-
you need only lumbar, so the dermatomes are very
Okay,
less.
we found that boluses work better because you get a concentrated effect of the lumbar. If
It
you use an
depends what
infusion, you get some
dermatomes you need to
spread
cover.
around all the facial
Yes.
planes, and the effect is not so good.
So
So
are
for
you
erector spinae
routinely
boluses.
using infusions for erector spinae, Rakhee, or
So we've realized that for orthopedic surgeries, epidurals work more effectively than erector spinae. In fact, we were doing a study to compare the both, and
Okay.
we realized that epidurals really work better. And it's a lumbar epidural, is pretty safe. So we have now stopped erector spinae. We give lumbar
So in
epidural.
spite of all the ultrasound, the central neuraxial blocks do have their place under the sun.
They have. But when it comes to thoracotomy, I would choose erector spinae,
Right.
because the spinal cord is right there. I don't want to mess with it.
Right. So thank you so much for that wonderful session, such brilliant inputs, such wonderful practical tips. I'm sure everyone is going to benefit. And we've had a very productive discussion. And I'd just like to reiterate the highlighted points that yes, assessment is necessary, but important things in assessment is that one, it should be regular. You must use validated age-appropriate tools. The assessment must take place before and after intervention, and it should be incorporated as part of vital signs charting. Peripheral nerve blocks under ultrasound guidance are here to stay. They have produced a paradigm shift. They're extremely safe. The learning curve is not very sharp, and a resident can very well learn them quickly. Central neuraxial blocks should not be written away. They still have a place under the sun. And intravenous analgesics have a lot to offer. Paracetamol being the cornerstone, but as Dr. Sethi has highlighted, there is a whole lot of drugs in our armamentarium today, which we can combine together to produce good quality analgesia. So a good assessment, a combination of regional together with parenterally delivered analgesics to produce a pain-free, happy child who can go home early, eat well. And you know, that little part of caring for the child when he knows he's in safe environment, he's with his parents, he can go home early, will help them heal earlier and heal better. So a very, very grateful thanks to all of you. And we close our discussion. If there are any questions, we would be happy to answer them. And over to you, Baljeet sir, because I can't see any questions in the chat box. I'm not very sure if there are any questions there. Only Ankita can tell us. Ankita, any questions?
No, I don't think there's
We
any.
haven't received any questions till now, ma'am.
Right. So thank you so
Uh,
much. And over to Baljeet sir.
I think they were all mesmerized with the discussion that was going on. I must compliment this one of the very, very thought-provoking and very focused discussion, whether it was in the presentations, which all the three speakers did an excellent job. Dr. Anju, Dr. Rakhee Goyal, Dr. Rakhee Goyal, and of course, Major General Navdeep Sethi as well. Lot of points were highlighted. I think Dr. Anju has very clearly summed them up beautifully. We were exceeding time. I just didn't have the heart to remind anyone that, because the discussion was so beautifully, being conducted after the presentations. The case discussions really brought out the best, or I would say the experience of all the three, learned speakers. And I'm sure this will go a long way in making the youngsters understand the need of pain relief, of course, and how to achieve pain relief, whether it is with the regional or local blocks, or it is, Dr. Navdeep very nicely highlighted, what we can do beyond the now blocks. Well, friends, thank you so very much. It was a great evening, excellent talks, and of course, beautifully moderated by Dr. Anju Singh with the case discussions. Thank you so much. Till we meet again next week. Stay happy, stay healthy. God bless you all. Good night.
Thank
Good
you.
night.
Thank you so much.
Thank you,
Thank
sir.
you,
Good
Desi
night.
ma'am.
Good night.
Thank
Good
you.
night.
Thank you so
Thank
much.
you.
Thank
Thank
you
you,
for
ma'am.
your time.
Good night.
Thank you
Thank
very
you, ma'am.
much.
Good night.
Thanks a lot.
Thank you so much, everyone, for your valuable insights. Looking forward to host you again on this very platform for the next sessions.
Yes.
So with all your due permissions, we would like to conclude the session over here.
Yes.
Thank
you.
you. Good night and take care.
Thank you.
Thank you.
Thank you.
Good night. Thank you, ma'am. Good night.